With further ado, so welcome all to our October edition of our Fireside Chat series for the Medical Valuation Laboratory. My name is Steve Parenti. I'm a professor here at the Carlson School of Management, and my co-host for this event is Tom Gunderson. This is our second year and more, Tom, that we've now moved to the fire, as it were, to Fireside. As you all know, things have gotten a little cooler in Minnesota, and everybody, you might have your dock still out, but your boat's probably in. At least that's the case for me. So now, hence our transition. We look forward to the summer again when it comes in 9 months or so. We are pleased today to have with us Larry Diamond. Larry is a Carlson alum, but also has a pretty distinguished alumni record, both with United and a variety of serial startups, and has a provocative title of Primary Care 3.0. I'm going to have in a second here Larry introduce himself. Before we do that, just to go through some of our customs of the chats. We are doing this with 30 minutes on the record, that is recorded, and 30 minutes off the record. So be careful with what you say. What we typically do is we'll have a conversation with myself and Tom and Larry for that first 30 minutes or so. And then go off the record, and then for those, basically throw it open to all of you. Make sure you put your hands up, put your camera on when you're asking a question, and we'll go through it. It's, as you all know, this is conversational, and we look forward to doing this again. One last marketing message. We have Millie Mondays coming up. I believe it's next Monday at my gosh, Tom, what's the name of that yard? Marshall Yards? Not Marshall Yards.
Malcolm Yards.
I was waiting for Alicia to correct me. Yes, Malcolm Yards. So we look forward to seeing you all there if you can make it. So without further ado, I'm going to turn it over to Larry and let Larry give a little bit of background to himself and why he's so passionate about what he's doing in this new space. I actually first learned about what Larry was doing over dinner almost a year ago and thought like this would be a perfect chat because it's just, with the rich experience he has and where he is with this, it just makes sense to have this be a broader conversation in our community. So Larry, the floor is yours to say hello.
Great, thank you, Steve. I'm Larry Diamond. I am the CEO of Mitesco. Mitesco is a public company, which is kind of unusual for a startup. We were able to acquire the team that had built MinuteClinic, and we're able to take their learnings and evolution, my experience, and put together a new business model focused on primary care as a consumer product. We're going to dig into that, but let me give you a little bit of background about from where I came. I actually started on Wall Street, which has been very helpful being in a public company. When you're a public company, you actually have two products. You have the business that you're in, and you have the stock that your shareholders own, and they are very different. And so you have to be aware of both businesses all the time. After Wall Street, I went back to actually graduate school at Carlson. And since then, in the last 30 years, have been working in healthcare for both United Healthcare, as Steve mentioned, spent 9 years there working in every different business unit they had over that period of time, and then got the entrepreneurial urgings to head out and started working for PE firms in a lot of technology, analytics, various kinds of disease management services, working consulting with hospitals, pretty much every aspect, pharmaceutical device. I've been involved in those businesses, and was given this opportunity here to kind of build something from scratch where we thought we had a new way of approaching the market where the timing was correct. And you've seen it in other aspects of healthcare where the consumer has raised their hand as they started paying for so much of healthcare. We saw that happening in primary care with the insurance rates going up, that we believe that, number one, people now cared and had a voice because of the dollars they were spending. And market research, the amazing thing, and people spend a lot of money on primary market research. We looked at secondary market research. It's all out there what the consumer wants. They are telling you loud and clear, and we just decided to listen. And that's what we're building here, in building in the good clinic. You'll see them around town. We have 6 clinics in town here. They're run by nurse practitioners. We believe nursing is better aligned for primary care because the practice of nursing is focused on working with an individual longitudinally to help them solve their problems, where medicine unfortunately has evolved to a one and done. Let me write a script, let me do a procedure, let me do something to move on. And so we're building these. They embrace both complementary and alternative medicine. It all depends on what the consumer is willing to consider when they're looking for help in managing their lives. It's co-developed. It's about getting the consumer involved and participatory in their care plan and working with us to solve problems, and then keeping care in the primary care office. Unfortunately, the way reimbursement has evolved, you can do the same thing in specialty care that a primary care clinician can do, but you get paid more. And it's not surprisingly that a lot of those services have evolved to end up in specialty care for no other reason than they're getting paid more. It's not has anything to do with skill. And then the other 2 evolutions that happened most recently is, number 1, nurse practitioners in 27 states and Washington, D.C. have full scope of practice equal to a primary care provider. And number 2, the government and insurance companies started paying for time. So when we spend more than 15 minutes, 30, 45, 60 minutes, we actually get paid for that time to spend with them to help people understand their illness, their situation, and come up with solutions from both a physical health and a behavioral health perspective. So we look at the whole person. So that's the background, Mitesco, the good clinic, what we're doing, and let's open up to conversation.
Larry, I find starting 6 clinics from scratch in the period of time that you've done this amazing, but still it's a drop in the bucket of overall healthcare in the US. Where do you see this going? How does this change the course going forward of how we deliver healthcare in your view?
There's so many ways to answer that question, but I think when you think about the models that we see around the world, you look at the French healthcare system, and they actually put their primary care clinics disproportionately right in neighborhoods, high density housing. So it's very, very accessible, and they have some of the best population health statistics. So when you think about what we did in building our clinics and what we plan to do going forward is to locate the clinics where they are readily accessible, there's easy parking, they're close to high rises, dense housing. So that's a key focus. When you focus on the consumer, you want to make it near the consumer as opposed to organized for the convenience of the provider, which unfortunately is what we have done for so long with these huge medical arts buildings, these hospital settings, and it makes it less convenient for the consumer. So I think that's a key change by bringing it back to the consumer, making it easily accessible, and now with technology, with video. Yes, we're going to see a lot of other ways to do that, but you need to have smaller clinics. So it's almost in the same model of a Starbucks. You know, we're relatively small, 4 or 6 exam rooms. We focus on same day, next day appointments. We can see where we're drawing from. And just like Starbucks, you know, you see them across the street from each other when the demand justifies it. We're no different than that. And I think, you know, that's the other thing that will shape this is in certain markets, you will see a much higher density of clinics so that things are very readily accessible to folks. And then there is a cost to building these out. It costs us about $1 million to build a clinic right now. We will focus on reducing that because we wanted to make it not look like a physician's office so that it was very approachable and comfortable. And so from that perspective, there's a huge infrastructure that will still have to be built. You know, New York City with City Clinic, City MD, they're taking a little bit different model, but very much focusing on pushing it into the consumer centers. So those are some of the major trends that I see this shifting. And yes, it will take a lot of evolution and revolution in healthcare and how we and where we deliver healthcare.
So that's my big question of what are the bigger trends? And thanks for the answer. That was very good. What, on the small side, you've opened 6 clinics, and if you're building the clinics where the consumer is, makes sense, right? What's the consumer telling you so far as to what they want? Is this asthma, diabetes, cancer, cardiology? What kinds of things are top of your list as far as the next clinics going out there, making sure they have those capabilities?
Great question. And the interesting thing is it actually changes as you go from neighborhood to neighborhood. And that's one of the core principles that we have is we want to make our clinics a component of the neighborhood. We partner with the Chambers of Commerce. We get to know the community, know what's important. In Maple Grove, we're working very closely with the city and their city workers. Women's health is a huge issue. In Nordhaus, it's a much younger population. And so the issues there, sexual health, behavioral health are two core, nutrition and how that fits in. Those are the kinds of things. As we move out into the suburbs, into more mature populations, again, you start to see a little bit more of the pulmonary issues and the cardiac issues. But again, we're primary care, and we're looking to make sure that we're the coordinator of care, and we refer out as appropriate, but we want folks to come back into us as quickly as possible. And so we have, referral networks. We have the ability, because we're independent, to work with any network. So whether you're with Allina or Medica, UCare, we have the ability to refer to keep the cost of the referral at a minimum. Did that give you what you were looking for?
Absolutely. You're focusing not only on where the customer is, but customizing by neighborhood what that customer is looking for. It makes a lot of sense. Steve, go ahead.
Yeah, so I guess the question, so I would describe this, you're basically coming into a community to make it bespoke. I guess the question is, to what extent is that bespokedness hard to replicate and scale? Kind of getting to Tom's question earlier. Is this, and as a complement to that question is, what communities might you think about going to after the Twin Cities that you think you can replicate that rolling in and listening model that you're thinking about?
So from I think as a spoke concept, hub and spoke world, in the denser populations, it tends to be a little bit easier than when you get out to more sparse and rural parts of the country where the travel times are much greater. When you think of that hub and spoke and the challenge that's been out there, most of the healthcare systems that we've run into and had conversations with don't like primary care. It's a lost leader for them. And part of it's the way they organize, because they have to keep their hospitals and their specialists full. And so what's being delivered in primary care today by most of the health systems is a 15-minute appointment that they're triaging to see if there are higher level services, higher billable services, and move that patient along, or simply dismiss the patient who is relatively healthy or needs focused on prevention and education. They're really not addressing those needs. And that's one of the core, what we're focusing on is really trying to focus on, and it's important, many of you know, 70% of Americans use about 20% of healthcare resources. 55% of resources are used by 5% of the population. Those are the ones that are really using the hospital system. Primary care was never meant to just really service that sick population. So when we look at our target market, we're really looking at that 70%, the people that on average are spending about $3,000 a year. They're relatively healthy right now. They have some issues, and we can keep them there and stable if we address those issues on a prevention basis and a focus to their immediate needs on a more timely basis. So that's that kind of that spoke perspective, keep them there, then to distribute them out as they get more sick and need higher level services. So I think that's possible. What was the second part of your question?
Where do you go to next? You're in the Twin Cities right now. How would you prioritize where to basically make your new build?
For us, the building, our next market is Colorado. We actually have 2 clinics under construction out there right now. We initially were looking for innovative markets that had a shortage of primary care. The AMA says the shortage is somewhere between 25 and 30,000 providers in America for primary care right now. And so there's not a shortage of opportunity. Everyone sees what Amazon is doing with One Medical, and Kano's been in the news, and Humana and CVS are chasing them. Primary care is a huge problem in America, and it's why retail health popped up. It's why urgent cares became popular, because it's a 2 to 5 week waiting period to get into primary care. And so when we look at it, we look at where are those shortages. We've had a lot of discussions coming in and being the primary care operation for some of the most influential and visible major medical centers in the country, because they don't want to invest in primary care. That's exactly where we want to be.
Okay. There's a question so good in the chat. I want to bring it out. So from Stacy, mentioning asking you to speak how this model might fit into EMR systems. The current concern is that they think Stacy says it's tricky, but love the community health, hope this could actually work. So I mean, I guess that you've been around the block on these things. Yeah, I know.
Yeah, sorry, Steve. My question was a little, not typed very well there. But in general, I love this whole patient idea. Of course, we have such a fragmented infrastructure, and so for that whole patient to be treated, how does the dissemination of information, when needed, like if my 9-year-old son, for example, goes to primary care, which he should, and then he breaks his arm, will there be access to that information? Maybe it's not needed, but I think as patients get sicker and older, I know I have health history that I would want the next person to have access to. Can you speak to your vision about that a little bit?
And I'm going to answer that several different ways. I mean, first off, so we just switched over to Athena Health as our EHR. And we're helping them to evolve because, we're a little different. We actually do same day, next day appointments. They had it so a client could cancel an appointment up until 2 minutes before they were there, or schedule an appointment before they were 2 minutes before. It doesn't work in that. I need at least 30 minutes to get ready for that. So we had to make some changes there. So they're learning with us, what does it mean to be responsive to a consumer? Now, from an information perspective, that is actually market dependent with the HIEs. What is the infrastructure to share that information? There's different ways that we can get it. There's a lot of different solutions in the marketplace, and it really depends upon what the individual Minneapolis, St. Paul, what are they doing to share information? So we will evolve and learn from that perspective. But a lot of it is telephone calls. We embrace telehealth completely. I actually come out of the telehealth industry. And so we can do consults with a referring physician, or we're referring to, so that we can share background with them so they understand the situation. But again, our first intake is a 60-minute appointment with a person. And it's really funny because after 15 minutes, people stop talking because they're so used and conditioned to not having more than 15 minutes with their primary care provider. They stop. And then our clinicians say, and what else? And so then everything starts to uncover and you dig in. And, all nurse practitioners are actually trained in motivational interviewing. And this is very key to get out what are the person's goals, their objectives, their challenges, what are their concerns. And in the medical record, many of you know, there's something called the problem list. And for a lot of patients, there could be 10 to 20 things there. In a normal primary care visit, you're going to get to 1, maybe 2. And the fact is, that may not be the thing that is blocking that person from getting better. And so by understanding their motivation, so we had one patient, they had 20 things. The reason they wouldn't move forward is their left toe hurt. And they finally said, until you fix my left toe, I am not going to do anything you're asking me to do. So sharing that information is part of the thing. Talking to the person, who they are, what their concerns are, is probably a bigger part of the challenge. And that's where we're starting to focus. The other pieces will come in time. It's still messy in every market that we've looked at.
Can I ask a follow-up? I'm sorry if someone else wanted to ask a question, but I just went to a recent Medical Alley chat, and there's a lot of cultural differences too. Is anything in your model trying to match up or help people that might be hesitant to come to the doctor, but there might be some different cultural approaches and things that might help?
And again, there's always multiple answers to a question. The first off is
Sorry.
we're actually using something called patient activation measure, which is out of University of Oregon, Dr. Hibbard, which actually defines at the 95% confidence level whether a person is an effective user of healthcare or not. And if they're not, how you have to communicate and how you have to parse your interactions with them in order to get them to be more successful over time. The neat thing about it, it is malleable. So you can move a person up in their participation. And the research shows that as you do that, you actually reduce the cost of care. The other part of your question, and probably where you're driving, is how do you get them to the dance? You know, once the person gets to the dance, I can teach them to dance. Getting them to dance, there is no silver bullet. And that's where communities and networks and outreach are so important. And, you know, the work that's being done with the Minority Health Association, which we're a member of, they have a lot of activities that are going on to make people aware of why you have to participate. You have to be proactive about your own health. And whether that's a family member or something else, that is a challenge. We're going to have to deal with that over time. There is no silver bullet there.
Thanks,
Thank you very much. Yeah.
We're gonna have some more Q&A too, for sure. But your questions were so good. I usurped my time. I gave you my time. Tom, you're back on. So I do have another question, but I'll wait until we go, if we go to Q&A for it. So Tom, go ahead.
Yeah. So let me get down into kind of the nitty gritty of a startup. And I'm curious, when we talk to hospitals, I haven't talked to a hospital in over a year that isn't complaining about the difficulty and the expense of their workers, right? So you've mentioned nurse practitioner a couple of times here. What are you finding? I think you have 30 to 40 employees right now. Is it difficult to hire right now? Are you having to pay up, or are there people that are out there that just say, oh my goodness, I've been waiting for a model like this for 10 years. I'd love to work for you.
Yes. Next question.
I don't know. Ask Stacy.
Yeah, I mean, it's a dynamic job market right now. And for the hourly employees that we have, people love what they're doing when they're here, getting them to come, getting them to stay. We're a startup, so there's certain precarious nature of the job. It's not like most people who've worked in healthcare for the big systems. They know that job is there. You know, that's not something necessarily when you come work for us that we can guarantee. There's a lot of growing pains that we have to go through. When it comes to the nurse practitioners, we are a job of choice. We can pick and choose who we want to come here. One of our NPs who recently joined, coming out of a major health system here in town, said they were expected to see 27 patients in an 8-hour shift. That's with a half hour for lunch. So now you're at 7.5 and 2 15-minute breaks. So in 7 hours, they had to see 27 patients. She said, I couldn't do it. With us, because we focus on minutes of care and keeping people there, and the way the government has changed things is they've reduced the documentation burden for longer visits. And so we're able to really focus in on what we're doing. And actually, state of Minnesota, on their Medicaid report, we're already in the second quartile on quality of care at the very high end. I don't know if we want to be in the top quartile because it's a cost offset there. We're pretty happy being in the second quartile at the top. I don't know if we're going to shoot for the other one. But it is a dynamic healthcare market. We do pay well in comparison to the statistics that we're seeing. And again, we have to attract and hold on to people. That's really important to where we're at right now. But we're not going to be any different than anyone else in non-nurse practitioner roles. But in the nurse practitioner roles, we are attracting really excellent people.
Very interesting. Back to you, Steve. So,
and I apologize, Larry, if I missed this. So reimbursement, are people paying you cash, or is it geared toward any insurance reimbursement at all? I mean, I apologize for being naive about this question, but it's late in the day for me. I've been up.
Yeah, no,
early.
we haven't covered it. Actually, no, we accept all types of compensation. So we expect 70% of our business to be insurance reimbursement. We expect 30% to be cash pay, and that cash pay is a combination of, we do sell supplements, essential oils, and educational materials in the clinics. We are now doing pharmacogenetic testing. Some insurance companies cover that, some do not. So that could be out of pocket. We're also now doing functional medicine testing. The majority of that is not covered by insurance. The exam is covered, but the actual test itself is not. So we actually have a partnership with a company called Exact Labs, who's actually, they're really neat, is they've gotten codes built into SureScripts. And so the results now from a pharmacogenetic test are available to any physician who tries to write a behavioral health med. So if the med doesn't align with their genetic code, they'll get a denial code for not a match with the genetic code. Huge breakthrough. And it's one of the reasons United started reimbursing for the pharmacogenetic, for SSRIs, for behavioral health meds. So we accept it all. We're going to continue to add other services. We actually look at the intersection of service and technology. So we're talking to a company who has a device that improves in vitro fertilization, and it raises it from 15% to 53% success. And they charge half of the standard IVF treatment. They've been unable to get it into market. There's so few IVF docs, and the IVF docs want to get paid $15,000, not $8,000. And so they're starting their own clinic. So we're talking about a partnership with them, co-locating. So those are the kinds of things, looking for ways to give people choice and access to services that are cost effective, whether it's cash pay. And we have a price list. Someone walks in, it's, here's the price list, it's what it's going to cost. Try and find that anywhere else.
So really, I mean, in some respects, this isn't primary care 2.0 or 3.0. This is, in a sense, what probably the retail clinic, and it makes sense, your background, this is what the retail model could have gone to had it really, in my mind, fleshed it all the way out. I mean, in the sense of going from just the McDonald's version of the parts list of like, here's your strep throat test, to like being far more comprehensive. Am I missing something from that? It sounds like there seems like there's a ton of stuff that you learned to realize what going to what the consumer really wants in a market to make this model work.
I mean, I absolutely, the consumer is definitely driving the directions that we're going.
Yeah.
We're also finding gaps, in Minneapolis, right now, to get a child assessed for attention deficit disorder, there's a 5-month wait. So we are looking to add in a psych nurse practitioner who can do that assessment. We have found a lot of folks that come in, their adolescents will be on multiple SSRIs, and they've never done a basic lab panel. So they don't know, is their thyroid working? What is their vitamin D, B, C levels? And we've been able to significantly reduce the number of those SSRIs that the person's on. We typically get it down to 1 when we fix their nutrition. And I think it goes back to Stacy's question, it's these stovepipes in the system, and they don't share information. And so a lot of what we're doing is we start from ground zero. You have to understand the physical health before you address the behavioral health.
Incredible. So Tom, do you want to close out one last question before we go off the record, or are we? You're on mute though. Sorry.
Just a comment, and that is, this is fascinating. And you say, well, we're just a startup and we're doing this and we're having to pay the hourly workers whatever we can and attract them to the startup business. But from an audience perspective, this is one of the paths to the future. We don't know what the future is going to be like. What we do know is it's not going to be like it's been in the last 10 years. So looking off into the future and looking at the consumer aspects of this and what works and what doesn't work, I think is fascinating. And that's what, now that we stop recording, we'll get into with questions from the audience. So thanks, Larry.